All right, welcome on in today. We're happy to see all of you. It's been a minute, but we're back with another Great Lakes ROTA-RC presentation. Today, we are talking about the harm reduction gap, implications for public health and medical providers. We've got a few housekeeping items per usual. We're going to get right into that today so we can hear from our presenter today. The first is to go through our funding acknowledgement. The Great Lakes ROTA-RC is supported by SAMHSA to provide training and technical assistance to the rural communities of Health and Human Services Region 5, which again covers Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. But if you're visiting us today from outside of that region, never ever worry. We're happy to have you from wherever you are from. So thank you for joining us today. As you can see, our website is located there, but as always, we provide all of that at the end of our presentation today. So do not worry, we'll pop that up in the chat for you to link to. Speaking of our website, here's just a quick snapshot of some of the resources that we provide through our website. We encourage you to go and check it out after our presentation today. You will be able to access our virtual education, our newsletter articles, a way to access technical assistance if you have questions, concerns in your local state. We can connect you to the ROTA-R office in your state to be able to get some of those questions answered and some support. We also have available community toolkits and resources, local news and updates across, within your state and across our region, and we try to provide funding announcements that affect rural areas. Talking about our newsletter, we do provide a monthly newsletter that talks about some of the things happening across our local region. We feature Ask the Expert articles. We try to support what's happening at the local level regarding prevention, recovery, and harm reduction. And then we also provide connections and updates regarding some of our technical partners. Just want to set the scene now as we move into our presentation today. And remind everyone that ROTA-RC promotes the use of affirming person-first language when discussing behavioral health disorders. We want to encourage everyone to use non-stigmatizing, recovery-oriented language that can help reduce negative bias and promote successful engagement in treatment and recovery. With that, I would like to introduce Sheila Vacara. She is the Deputy Director for the Department of Research and Academic Engagement at the Drug Policy Alliance. With that, I'm going to stop the share and hand it over to Sheila. Thanks, Sheila.
Great. Hello, everyone. It is a pleasure to join you. Let me just start my screen share again. All right. So I have about 90 minutes with you, and what I'm planning on doing is presenting for the first 60 or so minutes and allowing 30 minutes at the end for Q&A. However, I do encourage you to use the chat box if questions emerge as I'm going through the presentation, and I will try to keep an eye on it. So if it is something that I just need to clarify in the moment about something I'm speaking about, I might just pause to respond to your question right away. If it feels like something I want to get to more at the end of the presentation, I'll just let you know I see it and I will get to it when I'm done. So again, it is my pleasure to be with you today speaking about the harm reduction gap, the book that I wrote that came out this past February with Rutledge called The Harm Reduction Gap. I am the Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance, which is a national advocacy organization working to end the war on drugs. But my own experience that brought me to this work actually started after I got my master's in social work, and I initially started working at an abstinence-based 12-step facility in my rural upstate hometown in New York, in the northernmost tip of Appalachia, where I was a provider at one of the only 2 treatment facilities in our rural county. And I got to see firsthand what it was like to work in drug and alcohol treatment. The majority of my clients referred to care were mandated to services through parole, probation, child welfare, social services, or some other mandate. And we frequently worked with participants who were also in the drug court system. I was the drug court representative for the organization while I worked there. I later went on to work at a syringe service program where I worked with folks in New York City, who were experiencing homelessness and houselessness, living with HIV and AIDS, and actively using drugs. So folks would come to the syringe service program, and I was the mental health provider. After doing that for several years, I decided to go back and get my PhD. I was a professor of social work for several years, teaching students in the substance use counseling concentration at Long Island University in Brooklyn, and then ultimately getting the job here at the Drug Policy Alliance, where I've been now for 7 years. So my book is pulling together of the experiences that I had over the course of my professional career, but actually starting with my experience as a young person in the 90s who completed DARE drug prevention. I'm not sure about the age range of folks on the call, but I myself am an elder millennial. I was one of the early cohorts of young people who got DARE education, watching commercials on television about this is your brain on drugs. And so my book kind of weaves my own personal experience of growing up in this kind of culture of abstinence only, working in the abstinence only treatment setting, later getting a job in harm reduction, and how that evolved my thinking and beliefs. And I kind of put it all together in this book. So anyway, that's what brings me here to you today. And so in terms of my presentation, I have 4 key goals for what I'm going to cover with you all today. I want to summarize the key elements as I see them of the current approach to drug prevention and drug treatment that I believe have created what I'm calling and what I've coined the harm reduction gap in our current continuum of care. I'm going to explain how I see how drug criminalization, or the war on drugs, actually created and facilitated the creation of the harm reduction gap and contributed to the factors that I believed laid the foundation for the HIV/AIDS epidemic among people who inject drugs, and also created the conditions in which the public health impacts of the overdose crisis were exacerbated in the US. I will describe the 6 key harm reduction elements that I believe need to be integrated into our continuum of care to close what I am calling the harm reduction gap. And lastly, I will discuss how public health and medical professionals can help to close the harm reduction gap in their work at the micro, meso, and macro level. So a little bit of an ambitious agenda. So let's first talk about this overdose crisis. As many of you may know, we have lost over 1.1 million people in the past 25 years across the United States to drug-involved overdose death. Last year, 2023, it was estimated that we lost over 107,000 people to preventable drug-related overdose. One of the important things to do when we're talking about the overdose crisis is to make sure we're using the same terminology and coming from the same understanding to how we got to where we are over the past 25 years of this overdose crisis. And one thing that I find helpful when talking about the overdose crisis is to talk about it in terms of 4 waves. And this framework of the 4-wave overdose crisis was introduced by Dr. Dan Ciccarone, a medical doctor and researcher from the University of California in San Francisco. And the reason why we need to talk about the overdose crisis as unfolding in a process of 4 waves over the past almost 25 years is because over the past 25 years of this crisis, the drugs involved in overdose deaths have shifted and changed. The regional trends in how it's unfolded in different parts of the country have looked very different over time. The faces of people who have died has also shifted in terms of racial, ethnic, and age as well, in terms of who is dying of deaths. But also the ways in which the drug waves have shifted has had significant shifts across the country. So talking about it as happening over 4 waves is a helpful way to understand and acknowledge that the overdose crisis we're living in today isn't the same as it was 5 years ago, 10 years ago, 15 years ago, and that the policy solutions that we need to implement to save lives now are very different than some of the solutions that we tried to pass earlier, but also some of the policies that we passed earlier actually created the conditions for the crisis to continue to unfold in different ways over time. So many of you already understand the overdose crisis as starting in the early 2000s, being driven largely by prescription opioids, right? So hydrocodone, oxycodone, hydromorphone, prescription pharmaceutical opioid drugs that were prescribed by doctors and medical professionals to patients for a variety of health conditions. As many of you are now more than well aware, prescribing practices changed in the late 90s and early 2000s due to pharmaceutical marketing practices in which a new formulation of opioid was marketed as less abuse, like more abuse deterrent and having less abuse potential than opioids had in the past, because prior to the 90s and prior to the advent of oxycodone and new formulations of it, doctors really didn't prescribe opioids for pain. And when they did, it was for long-term hospice pain or within the confines of medical care in a hospital-based setting. Yet this new formulation of opioid was marketed as having less abuse potential and for being applicable to wider ranges of pain, which had otherwise been treated with other forms of analgesics and over-the-counter medications, right? And so through the marketing of these medications and targeted efforts to increase rates of prescribing among doctors, we saw a flooding and in the availability of prescription opioids in people's homes in the late 90s and early aughts for a variety of conditions in large doses and quantities, oftentimes, and without the respective risk education to patients about dependence potential, interaction effects, risk for overdose, and ways to monitor your use, right? And so we saw overdose deaths start to increase, first in Appalachia, areas like West Virginia, which many people talk about, and the Rust Belt. And we saw high rates of dispensing. And overdose deaths were among people who were the patients that these medications were prescribed to, but also family members, friends, and acquaintances who had been shared the medication, who had stolen the medication, or who had bought the medication from patients with legitimate prescriptions, right? And so we saw the beginning of this first wave of the crisis, one that involved rural and white people, and also suburban white people, and a younger demographic that had historically died of overdose in American kind of culture and like based on American like drug trends, right? And so what did we do when we started to see prescription opioid overdose deaths go up? Well, first and foremost, authorities took steps to reduce prescribing practices among doctors and dispensing practices among pharmacies, right? We saw the widespread proliferation of prescription drug monitoring programs. We saw doctors and pharmacists being targeted by law enforcement for their prescribing and dispensing practices. And we saw lots of crackdowns and enforcement side approaches to reduce the availability of prescription opioids, right? But the problem was that we didn't do a matching investment in healthcare or treatment or evidence-based approaches, right? So even though we all of a sudden started cracking down on supplies, it's not like we were actually addressing the demand for these opioids, and we weren't necessarily facilitating access to evidence-based treatments or investing in as many of those kinds of public health approaches, right? And so what did we see happen? We reduced the availability of prescription opioids, and many people started turning to the underground market to buy diverted pills, oftentimes which were marked up because it's very expensive to get legitimate products in the underground market. And what we saw was that a lot of folks were being offered heroin instead of prescription opioids because it was much more cost effective. What had happened in the early 2000s is that while historically heroin in this country for decades had been sourced from outside of North and South America, we saw that in the early 2000s, Mexican cartels and Colombian cartels had found ways to grow heroin in Mexico and Colombia, and we had new supply chains open up. And it meant that actually heroin quality was very good, and it became very cheap. So the rapid availability of very cheap heroin as prescription opioid supplies were getting cut down led a lot of people to transition to using heroin, those who had already developed a physiological dependence on these drugs, right? And so what did we see by the time 2008, 2009, 2010 happened, when some of these crackdowns on prescription opioids happened, was that we saw this orange line, which is the heroin line in overdose deaths, start to come up. And this is when many of us say the second wave of the overdose crisis happened. And again, regionally, it was still in the same areas that prescription opioid deaths were very high in. So again, now we were seeing people dying of heroin-involved overdose in those same rural and suburban areas of Appalachia and other parts of the country where this prescribing had gotten very widespread. Now these folks were now shifting to heroin and again, dying of overdose because when you buy a prescription opioid, at least it tells you how many grams or milligrams are in it. When you buy street heroin, you never know what you're going to get in a bag, right? And so people were taking unknown qualities and potency of street heroin, not understanding the risk for overdose. And so that is when we saw that orange line start to pick up in what we call the second wave of the overdose crisis. And so what did we do? What did our policymakers do when we started to see heroin-involved overdose deaths go up? Well, they engaged in more efforts to seize heroin at the border and engage in heroin busts across the nation. And they thought, again, if we're calling this an opioid crisis and the problem is heroin now, we need to get heroin off our streets. But again, only focusing on reducing heroin availability did not get at the underlying reason why people were still using and seeking heroin. And so what we saw was that there was still a demand for street opioids, but now heroin wasn't there and available to meet those needs. And as heroin supplies got more disrupted, suppliers needed to come up with more strategies and more product to push on the street. And they couldn't keep up with the fact that so much of their drug was getting lost in seizures. And this is when chemists in the underground drug supply who worked with these cartels and drug trafficking organizations realized that they could create a synthetic opioid that could help to meet heroin supply demand or meet heroin demand on the street if they simply procured the chemical components that they needed to make them. They wouldn't have to wait for the life cycle of an opium poppy plant. They wouldn't have to sit around waiting for the farms to grow these opium poppies to be able to make heroin. We can simply just buy the chemicals on the dark web and then mix up this potent fentanyl and cut it into our street supplies so that users get the drugs that they're looking for. However, when this phenomenon happened, drug users and low-level drug sellers did not get a memo about it. Simply the heroin supply changed, right? And this is when we saw the beginning of what many of us call the third wave of the overdose crisis. Heroin supply now was getting deeply restricted and fentanyl was being cut into the heroin supply, unbeknownst to users who were accustomed to using known quantities of heroin, but now all of a sudden the bag that they usually bought was much stronger than what they expected. Fentanyl started getting cut into our heroin supply. Estimates suggest around 2014, 15, and 16, starting here on the East Coast, but eventually shifting more westward. And what we saw was that because drug supply chains don't differ between the suburbs and then the big cities, that by the time that fentanyl was cut into the street heroin supply, now we started to see deeply entrenched drug networks in big cities like Boston, Baltimore, New York City, Chicago, and Washington, D.C., places where we had long entrenched heroin using networks where people had been using heroin for decades, lots of low-income white people and communities of color. Now, all of a sudden, their heroin had also changed composition because the drug supply was so disrupted. And so when the third wave of the crisis happened, this is when we actually just started to see a different region impact, right? So from going from rural and suburban, now we saw inner cities overdose death rates start to go up, especially along the East Coast. But in addition to it changing in terms of rural versus urban, it also now changed in terms of its face because we started to see racial and ethnic minorities have higher rates, growing rates of overdose deaths, which we had not seen characterized in the early two waves of the crisis. So this line shows you the fentanyl-involved overdose deaths. You can see how as soon as fentanyl entered the East Coast drug supplies, deaths started to go up. And what you'll notice is that starting in 2020, which I'll get to a little bit later, this is when around 2019, 2020, fentanyl moved west of the Mississippi. And so in those first few years of the crisis, this early part of this line is actually just mostly the East Coast and some parts of the Midwest. And really 2020 and beyond is when fentanyl finally moved west. So that's another regional shift that started to happen. But another thing that's worth noting is that we then emerged around 2017 into what's known as the fourth wave of this crisis, wherein we saw an increase of involvement of stimulant drugs in overdose deaths. This light blue line is cocaine, and this purplish line is methamphetamine. So in this fourth wave now that we're in, starting around 2017, not only are fentanyls driving overdose deaths, but we also see oftentimes a co-involvement of a stimulant drug. On the East Coast, cocaine-involved overdose deaths went up. On the West Coast, we see a lot of increase in methamphetamine overdose. And in parts of the Midwest, it depends on the state, but either it's cocaine or it's methamphetamine. And this fourth wave of the crisis, wherein stimulants also are available and driving overdose deaths, again, this is where some of those racial disparities have become more entrenched. In 2018, Native people emerged as having the highest rate of overdose deaths compared to all other racial and ethnic groups, including white people. And after 2020, Black people even had higher rates of overdose than white people. And although Latinx communities have relatively low rates of overdose, their rates of overdose are dramatically increasing. So all of this to say, it's really important for us when we think about the overdose crisis to see it in terms of being related to policy side choices that we made to crack down on drug supplies, but instead of it eliminating overdose, it incentivized the introduction of new drugs that often started to drive more deaths. So now we're going to talk a little bit about the prevalence of drug use in the United States. So this is imagine that this larger circle reflects the entire US population over the age of 12. And this data is all from the Substance Abuse and Mental Health Services Administration, their annual survey called the National Survey on Drug Use and Health. And so you'll see this large bubble is the entire US population over the age of 12. And this is research as recent as 2021. And what they found is that when they asked survey respondents, about 60,000 nationally representative people from all 50 states in counties that are both rural, suburban, and urban, that anyone over the age of 12 in a house was asked to answer questions from this survey, and they knocked on doors across the country. They found that about 70% of people, when asked from this survey, said that they used alcohol, tobacco, nicotine, or an illegal drug in the past year. Alcohol being the most commonly used drug, followed by tobacco and nicotine, followed by marijuana, usually. And then when they zoomed in and they asked, did you use any of these substances in the past month? About 58% said, yes, I used one of these in the past month, right? And when they zoomed in even more and then asked follow-up questions to determine, are these people occasional users, heavy users? Do they meet criteria for a substance use disorder or an addiction? They found that 16.5% of respondents met criteria for a DSM-5 substance use disorder. And when they asked people who met criteria for a substance use disorder, did you receive any sort of drug or alcohol treatment in the past year at a treatment facility? Only 1% said that they received treatment in the past year of the general population. But if you think of it, that circle as being situated in the bigger circle, that's about 10% of people with addictions receiving treatment, 1% of the broader population having received treatment, right? And so why did I just go through all of this with you, right? Why did I just describe the overdose crisis on the one hand, and now why am I talking about the prevalence of substance use, right? It's really important for us to remember that not everyone who uses drugs meets criteria for a substance use disorder, right? If in fact, the majority of people in this big circle, in this bigger circle, did not meet criteria for a substance use disorder, right? The majority of people who use substances do so occasionally or even more frequently socially, but they don't experience enough negative consequences to rise to the meeting of a diagnostic label of having a substance use disorder, right? And so I think it's really important for us to think, okay, so if 70% of people across the United States over the age of 12 used one of these mood-altering substances, if we are in the midst of a 25-year overdose crisis where we've lost over 1.1 million people, what does our continuum of care currently look like for substance use? This is how I see it. On the one hand, we have abstinence-based drug education, right? This idea that if we teach young people to fear drugs, to be scared of drugs, and if you came up like I did in the 90s, to think that drug use was going to create mental illness, crime, or death, which was often the message that we received in DARE education. Anyone on the line who's been through DARE probably remembers this kind of messaging. The idea was that if we tell young people and scare them enough so that they don't use drugs, we could prevent a future generation from becoming addicted to drugs, right? In theory. Yet what happened was my generation, the DARE generation, actually used drugs at much higher rates, even though we completed DARE, right? And so after this just say no messaging, what is available in our continuum of care? The only thing we've got is abstinence-based drug prevention or drug treatment, right? And that's for people who meet criteria for a substance use disorder. So not the occasional, social user, but if you do let the just say no message expire, the day you have your first sip of alcohol, the day you smoke your first cigarette, the day you do your first bump of cocaine, you have basically undone your drug prevention education, but then we have nothing left for you in terms of learning how to stay safe, learning how to make sure to reduce risk, right? Instead, the only thing we have is if you develop an addiction or a substance use disorder, we have a treatment system that's largely abstinence-based that includes options such as detox, inpatient, residential, methadone clinics, outpatient programs, but there's nothing else in the middle. And this is why what I'm calling the harm reduction gap, because we don't really offer our communities anything outside of abstinence-only drug prevention and abstinence-only drug treatment, because there's nothing for the social user, there's nothing for the occasional user, there's nothing for the recreational user, but even for the person who meets criteria for a substance use disorder and doesn't walk in the door of a treatment facility, i.e. 90% of people with addiction and substance use disorder, we actually have nothing available to them, right? And what about those who never want, seek, or need treatment, right? So I argue that all of us, the majority of us who use substances, those 70% of people who used one of these substances in the past year, fall into what I call the harm reduction gap, where we could have been receiving tools, education, and support around staying safe with drugs, but instead are often left to figure out how to stay safe on our own, and oftentimes can lose our lives during that process, right? And what again is harm reduction? According to the National Harm Reduction Coalition, harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. And harm reductionists believe and know that it is possible to arm those who use drugs with the tools and skills to stay as safe as possible right now. And for the most widely used drugs, such as alcohol, learning strategies about staying hydrated, using the buddy system, making sure to eat before drinking, being aware of the interaction effects of alcohol with the medications that you may be taking, but then also with other drugs when it comes to tobacco or nicotine, or when it comes to drugs like cannabis and marijuana, which have been legalized in more states, but also for illegal drugs, right? And harm reductionists believe that it is far more practical and realistic to take a harm reduction approach than to simply hope that people who use drugs can figure out how to stay safe after leaving and graduating and completing their abstinence-based drug prevention education of their youth. And harm reductionists are willing to help people with substance use disorder without fixating on abstinence as a prerequisite, thereby potentially being able to serve people who have more diverse goals for their substance use or who do not quite fit into the abstinence-only models of the treatment facilities that currently are available to them. Yet, why is harm reduction not the mainstream approach or the conventional approach in the United States to treating and addressing risky drug use? I would argue, and I argue in the book, that one key reason that we do not have harm reduction as the mainstream approach to drug use in the United States is because of the war on drugs or drug prohibition, or also just the known as the criminalization of drugs. And so why do I say this? Because actually, when you look at the history of our policies when it comes to drug use, it wasn't always that drugs like heroin, cocaine, MDMA, and even marijuana were illegal in this country. In fact, there was a time in our history, a little over 100 years ago, when none of these drugs were regulated or illegal. They were just freely available. And eventually, some of our policies shifted to regulating the availability of some formulations in some formats in some ways. And then eventually, we passed the laws to criminalize drugs. However, our war on drugs in our broader history is more of a recent phenomenon than it is one that started with the beginning of this country. And so here is an image of a bottle of this drug called heroin. And what you'll see here is that it's an advertisement from the early 1900s. And you'll see here that it's an advertisement from a company that some of you may be familiar with, Bayer Pharmaceuticals. So just like many of us, when we put a bandage on, we don't call it a bandage, we call it a Band-Aid, right? Because that's the brand name. We may not call it a box of tissues, we call it Kleenex, right? In the same way, diamorphine, or hydrochloride diamorphine, was marketed as heroin. Heroin was actually the brand name, just like we call Aleve or Tylenol, pain relievers. So Bayer Pharmaceuticals was selling heroin, an opiate drug, at the turn of the 20th century, and they named the composition that they had made heroin. And they sold it as heroin because they believed that people would buy it because they derived the name heroin from the word heroic. So if they marketed this drug as something that can make you heroic and able to work and strong, and a way to also help relieve coughs, to address pain, that they could help treat a variety of ailments that were facing people at the turn of the 20th century. And they marketed this to people directly. So there was no need for prescriptions at the time. And it was the brand name of a medication to try to get people to buy it. And other companies also tried to market opium and opium-derived drugs in tonics, tinctures, lozenges. They said it would help with anxiety and nervous disorders, gastrointestinal problems, respiratory problems, menstrual cramps, and other ailments. And population surveys in the 1800s showed that white Americans from all walks of life were using opiates like heroin, including Civil War soldiers, housewives, working men, the educated, and the wealthy alike. During this time, middle-class white women emerged as the dominant consumers of opium products for both psychological and health issues. Though these drugs were legally available, productions and sales were not regulated, so people often didn't know how much they were consuming, and they also didn't know whether these contents had been tested or verified for the claims that were made for what they were marketed for. And they received no education or warnings about opiate-related risks. Sound familiar, right? And this meant that people could easily purchase opiates and use them as a cure-all, but oftentimes were unaware of potential harm. As opiate use became more prevalent, it soon came to be viewed as a social problem because eventually growing segments of the population developed physiological dependence, meaning withdrawal and tolerance symptoms, on these drugs, and they often needed more doses and higher quantities to get the same effects. And it was suggested that at the turn of the 20th century, 250,000 Americans were somehow dependent or addicted to opioid drugs. Yet, despite growing concerns about opiates, there were no bans proposed on these patent medications, like the one that I have here. Instead, the only form of opiate use that gained any sort of public scorn or concern or stigma was the smoking of opium. And as I told you, these tonics and tinctures could have been drank or taken in lozenges or even bought in syringe form. And why was smoking the only one stigmatized? It was because smoking was associated with Chinese immigrants who came to the United States during the 1850s for the gold rush. and they also worked on the railroads in California. Chinese people had a complicated place in American society at that point in history because they were seen as competition for jobs during high domestic unemployment. And anti-Chinese sentiment was prevalent because they had a different culture, they had different practices, they had different language, they had different everything, right? And they were frequently subjected to a lot of racial discrimination. And many laws were passed to restrict the rights of Chinese immigrants at the time. And during this time, Chinese immigrants in Chinese neighborhoods, predominantly Chinese neighborhoods, would open opium dens predominantly to serve their own communities where they could relax and smoke opium as a recreational activity. And while Chinese people were the predominant clientele, there were some white people who started to come to them. White men and women would start coming to these, rich and poor alike. But at the time, interracial socialization was not encouraged in American culture. And these white men and women were very concerned about the corrupting influence of these Chinese men on vulnerable communities, vulnerable white communities. So you'll see here in this image, which is a real image that shows, this depiction of a white woman sedated here, lying in this kind of cot. And this being kind of like this corrupting influence that they have here, right? And so this idea that these Chinese opium smoking dens were going to corrupt white women. And so they actually led to San Francisco passing the first ban on opium smoking in 1875. And it was the first anti-drug law in the United States. And over the next several years, other jurisdictions also passed similar laws. And basically what they wanted to do was criminalize the form of opiates that Asian people were using, but not the medicines that were known to be used and prescribed to white people, right? So again, this kind of imagery here of the yellow terror in all of his glory were used to kind of fan the flames of restricting access to opium to racialized groups in forms that were recreational, because the only forms that should be used are these medicinal forms, right? And meanwhile, cocaine was first extracted from coca leaves in the 1850s, and it came to the US soon after. And here you'll see cocaine toothache drops. Many of you, if you've ever had any dental work done, you have likely benefited from Novocaine. And if you haven't questioned it before, I would encourage you to think about the CAINE at the end of Novocaine. It is pharmaceutically a cousin of cocaine, because even cocaine can numb your, has like mildly anesthetic effects, topical anesthetic effects. And so you'll see here that pharmaceutical companies quickly wanted to make cocaine available for toothaches, but also in other forms to help increase worker productivity. And Sigmund Freud thought it had great psychological benefits as well, because it was very stimulating and it promoted wakefulness. And like opium, cocaine was added to beverages, medications, and tonics. It was used as a topical pain reliever and actually even as a treatment for opioid or alcohol addiction. And even the first, we talk about Coca-Cola all the time. I'm drinking some right now. Coca-Cola did, in its original formulations, have derivatives from the coca plant. And when they finally removed coca derivatives from it, it became what we now call a soft drink, right? We call these soft drinks. So anyway, while cocaine addiction did happen during this time, it wasn't as widespread as opioids, because you don't see the same physiological dependence syndromes, the withdrawal and everything. But like opium smoking, cocaine also became associated with its own racialized fear-mongering that motivated restrictive policy changes. Cocaine was cheap and its use spread to the South. And white Americans became concerned about how cocaine would turn the freed Black community into a violent threat, even though white Americans were the predominant users of the drug at the time. And so a clear example of racialized fear-mongering when it comes to cocaine can be found in this real headline. This is from the New York Times in 1914. And you'll see here in this cover, it says, "Negro cocaine fiends are a new Southern menace." The article sensationalized anecdotes from Southern sheriffs about supposedly dangerous Black men under the influence of cocaine who became better marksmen. So they were better at shooting, they were more accurate at shooting, and who were somehow impervious to regular bullets. So sheriffs argued that they needed bigger gauge bullets to stop Black men in their tracks because the cocaine made them so strong that they wouldn't be able to get shot down with regular bullets. But they also argued that they needed more support because Black people on cocaine were a public threat. And so articles like this, along with films like Birth of a Nation, which perpetuated the myth that Black men were predators trying to rape white women, really led to the fear of the freed Black person being influenced by cocaine at the same time that we know in American history, lynchings were at their peak. And legal segregation was being argued as a solution, and voting laws were being passed to restrict Black rights, right? And so from the beginning, drug-related stigma was created and weaponized, particularly around non-medical use among these feared racial groups, while medical use was touted as a solution for middle-class white health problems, right? So you can fast forward to, I'll get to 1937 in a second, but so what this all led to was by 1914, what we saw was that we passed the Harrison Narcotics Act, which was the first federal law that targeted specifically heroin, opium-derived drugs, heroin, and cocaine as needing to be taxed if being given out. And it was a way to kind of tax medical use, but to start trying to restrict any form of recreational use. Within a few years, we banned heroin altogether. And we were starting to lay the foundation of our modern drug war, right? And so in 1937, in the years leading up to 1937, fear-mongering started to be developed around marijuana. But at that time, Americans only knew it as cannabis. Cannabis was a widely grown crop because of hemp. Hemp was an industrial fiber that was grown by many of our presidents, and it was a widespread industry for industrial purposes. Hemp was used for a variety of things. Yet around the early 1900s and the Mexican Revolution, a lot of Mexican people migrated to the North looking for jobs. They came to the US looking for jobs. And again, they were competing with low-income whites for jobs. And much like the fear-mongering that happened around Chinese migrant laborers, these Mexicans were being depicted as chronic users of marijuana, or of cannabis, smokable cannabis. And although Americans sometimes smoked cannabis and some medicinal tonics had cannabis in them, it wasn't something that a lot of people were aware about until some of these headlines started popping up saying that Mexican people were using this drug and it was leading them to become dangerous. And so Harry Anslinger, who was a key government official at the time and had the ear of a lot of high-level politicians, suggested that there were 100,000 total marijuana smokers in the US. Most are Negroes, Hispanics, Filipinos, and entertainers. Their satanic music, jazz and swing, results from marijuana usage. This marijuana causes white women to seek sexual relations with Negroes, entertainers, and others. And in trying to pass the first federal law against the availability of cannabis, he deliberately made the choice to call it marijuana, so that using this kind of sensationalized ethnic sounding name, it made it seem like this new foreign, exotic, scary drug that was being used by these foreigners that was creating havoc in communities and putting communities at risk, right? And so although he couldn't get marijuana added to the 1914 Harrison Narcotics Act, he spent the next several decades trying to garner enough fear so that by 1937, eventually we passed the Marijuana Tax Act, right? And so you can see here that the foundations of our drug war started being laid quite early on. You know, many of us think of the 1970s and we think of Nixon as the beginning of the drug war. But what you can see here is that we started trying to crack down on certain drugs pretty early on. And what we were trying to do was create a two-tier system, one where we could preserve medical access for certain communities in certain formulations, but one where the other types of usage that were seen as recreational or social occurring among racialized minority groups who were seen as a threat was seen as something worth cracking down on or punishing, right? Yeah, so let me keep going. So let's fast forward though to 1970. This begins the beginning of the war on drugs as many of us think about it, right? This was passed under Nixon. And under the Controlled Drug Abuse and Prevention Act, there were several things that happened. First of all, we created a drug scheduling system. So many of us know of drugs as being Schedule 1, 2, 3, 4, and 5, right? Schedule 1 drugs having the highest penalties, Schedule 5 drugs having lower penalties. But Schedule 1 and the scheduling system that was developed in the 1970s was meant to distinguish drugs along two criteria: their potential for abuse and addiction, and their medical potential utility. And so drugs that were placed in Schedule 1 were drugs that were supposedly highly addictive and had no potential medical usage, and thereby needed to have the highest and harshest penalties to prevent their availability and to prevent their use. And then drugs in Schedule 2, 3, 4, and 5 would be drugs that have some degree of medical utility in certain circumstances, but that also ran the risk of some degree of addiction. So we needed to be careful about how readily it was prescribed and how readily it was available. Strategically, though, Schedule 1 drugs are a very interesting combination of drugs. Heroin was made a Schedule 1 drug. Marijuana was made a Schedule 1 drug. LSD was made a Schedule 1 drug. Psilocybin was made a Schedule 1 drug. Meanwhile, drugs like cocaine, methamphetamine, other kinds of opiates were actually given Schedule 2, 3, 4, and 5 delineations because we acknowledge that some of those formulations had medical utility, right? You think about the way that we prescribe amphetamines, for instance, for ADHD and narcolepsy, right? And we think about the ways that we do use opiates in medical treatments and surgeries, right? Those are just some examples. And interestingly enough, you fast forward to today, some of those drugs that we put in Schedule 1 are now being seen as having medical potential, right? We're hearing about psychedelic-assisted therapies. Obviously, like many states have medical marijuana policies. So how is it that some of these drugs that we even know now have medical utility ended up in Schedule 1? Here's a quote from John Ehrlichman, who was kind of Nixon's right-hand man at the beginning of the 1970s and the drug war. You want to know what this was really about? Nixon had two enemies, the anti-war left and Black people. We knew we couldn't make it illegal to be either against the war or Black. But by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily by putting them in Schedule 1, we could disrupt those communities. Did we know we were lying about the drugs? Of course we did. And so what we started to see here is the beginning of, as some drugs became criminalized, we carved out the availability of other drugs for medical access. And very clearly, even the architects of these laws explicitly said that racialized groups could not be trusted to use certain drugs. And so by associating certain drugs with racialized groups, we could justify punishing them and criminalizing them and controlling them. But we always wanted a carve out for the white middle class user to have medical access to certain formulations. And what did we do with the scheduling system, right? I just told you that we said Schedule 1, 2, 3, 4, and 5 based on abuse potential and medical utility. Did we put the authority of the Controlled Substances Act under a medical entity? No. We put it under what would then become the Drug Enforcement Agency, a law enforcement agency. So one other thing that Nixon did was not only did he create this system that was going to carve out medical access and carve out criminalized access, but instead of saying that drug use was a health issue, this is when drug use became under the auspices of law enforcement. Do you see that? Because we could have said, let's put this under what would be in the future the Health and Human Services Administration. Let's put this under the Food and Drug Administration. Let's put this under a medical or a research entity to continue to research these drugs to make sure they're being determined for medical use. They're being determined for abuse potential. But no, we said, let's put the authority under law enforcement, right? And this laid also the foundation for the beginnings of some of the challenges that we started to see as the overdose crisis unfolded, right? Because who has the authority to determine whether, up until very recently, a prescriber could prescribe buprenorphine for opioid addiction? You had to have a DEA waiver, right? Why is it that opioid treatment programs, methadone clinics, don't get visited by health authorities? They get visited by the DEA to make sure that they've locked up the drugs safely. They're secured, everything accordingly. We put, the DEA being in charge of these medications has actually led to the restriction of the availability of some medications for valid medical use, right? But one other thing that we don't think about that also happened with the war on drugs was that once as we criminalized the drugs in 1970, people could still potentially go to a head shop like the one here on the left, where they could buy pipes and bongs and things like that, right? And, at in the early 1970s, this was a multi-million-dollar industry, selling all the tools and equipment that people could still use to consume drugs. And parent groups were very concerned about head shops in their communities being able to sell the tools to use drugs. And they were afraid, well, if my kid walks past a head shop where they sell bongs, even though marijuana is technically illegal now, it could encourage my kid to want to try drugs if they see a bong shop. So we should actually go after these shops and make it hard for people to buy these tools, because we can't just criminalize the drugs. We also have to criminalize the tools that people are using to consume these drugs. And so states started passing laws to ban head shops like this one. Yet what happened was a lot of the shop owners were able to say, hey, in theory, they could be using these tools to smoke tobacco. I don't know what people are going to be smoking with this stuff, right? And so a lot of these head shop owners were able to push back against laws that were trying to come after them to shut down their shops, because they said, we don't know what people are going to use these for. And so the DEA got involved. And they drafted up a model bill, and they said, we will give you the language that you can now copy paste into your state law to prevent the opening of these kinds of facilities. And we'll make it bulletproof so that no one can refute it in a court of law. And it'll mean that these shops can't open anymore. And it'll restrict access to now the tools to use drugs. And if we, again, with the logic being, if we criminalize the drugs and now criminalize the tools to use drugs, people won't use drugs anymore, right? And so they defined paraphernalia in the Model Drug Act that many of our states have on the books right now to this day as all equipment, products, and materials of any kind which are used, intended for use, or designed in use in planting, propagating, cultivating, growing, harvesting, manufacturing, compounding, converting, producing, processing, preparing, testing, analyzing, packaging, repackaging, storing, containing, concealing, injecting, ingesting, inhaling, or otherwise introducing into the human body, a controlled substance. And so basically, this model legislation was meant to give states the tools to prosecute people for having pipes, crack pipes, meth pipes, but also pipes for smoking weed, syringes for injecting, right? Baggies, scales, plants, any kind of equipment for a grow house or a grow room, but also drug checking, any sort of machines for analyzing or testing drugs, right? And so when this law was passed, in many states, when versions of this law were passed across many states, we now saw states restricting the availability of syringes for non-medical use. And this is what then laid the foundation 10 years later, less than 10 years later, for the HIV crisis among people who injected drugs, right? Because if people who injected drugs had no legal way to get syringes, what did they do instead? They bought their syringes from their dealer. They shared syringes with other people who injected drugs. And that is how hepatitis B, hepatitis C, and HIV spread among people who injected drugs, right? And it was because most states in the 80s already had laws on the books criminalizing the availability of syringes for non-medical use, right? And so what happened? Harm reduction advocates started to realize, and people who use drugs said, one of the reasons why HIV is spreading in our communities is because we don't have legal access to sterile syringes. And so when they started to procure syringes and start distributing them among people who use drugs, right, to prevent HIV, they were technically breaking state and federal laws, right? And many syringe service advocates at that time and harm reduction advocates were prosecuted and charged and arrested under these laws because a public health crisis emerged as a result of the war on drugs. This law, right? And fast forward to today, where states are trying to pass laws to expand access to fentanyl test strips and xylazine test strips and more advanced drug checking. And many states have laws on the books like this that criminalize anything for the testing or analyzing of drugs. And so what happened is in the 90s, a lot of these advocates started to try to change their drug paraphernalia laws and carve out the language around injecting equipment, right? And in a lot of states, recently, we've seen changes in laws to take out testing and analyzing so that people can give out fentanyl test strips. And in states where we try to give out smoking equipment to people who smoke meth and crack, they're also trying to take out the language around inhaling. But with these kinds of laws on the books, it's made harm reduction harder to do. Because if you have a state that has this sort of this language built into the policy, they've built in to their policies laws that transmit HIV and AIDS among people who inject drugs, make it harder for people who smoke drugs to get safe tools to smoke drugs, but also make it hard for people who use underground drugs to know what is in their drugs to be able to stay safe, right? And we can also fast forward to talk about, the 80s under Reagan. This was my childhood. This is all my memories of my youth. Again, when we saw the emergence of the crack epidemic, right? We saw crack cocaine rates increase. We saw, but also a simultaneous disinvestment and overinvestment in policing in urban communities where social services, family support, medical support, healthcare, all of those things should have been more available, but instead pinning social problems on a drug rather than structural and systemic challenges and investing more in punishment rather than actual supportive services for families and communities, right? This is when we started to see fear-mongering around crack cocaine being some sort of new, very risky, dangerous drug and a formulation that's so different from powder cocaine that this is when we saw the institution of the 100-to-1 penalty disparity in the sense that 100 grams or 100 units of powder cocaine would be subject to the same amount of penalties as just 1 unit of crack because we fear-mongered that somehow crack itself was somehow more dangerous than powder cocaine. And what it meant was that law enforcement going after poor communities and communities of color for crack, they would get targeted for small quantities, but they would get huge penalties. The Fair Sentencing Act, a little over, under a decade ago, reduced this disparity from 100-to-1 to 18-to-1, but that disparity still remains. The other thing that happened during the crack era was that our current president, Biden, was a sitting senator. And in his attempt to get involved with drug policy at the time, he introduced something known as the Crack House Statute. The Crack House Statute said any landlord or building owner or person who owns a business who knows that on their facility grounds, someone might be using drugs or it facilitates drug use, that they could then lose their lease in their building and they could be subject to criminalization. And they called it the crack house statute, saying that anyone who knowingly operates a place where people use drugs, i.e. a crack house, could now be penalized. So whereas our drug war started by first criminalizing drugs, then criminalizing the tools to use drugs, and then criminalizing the spaces where people use drugs, we created the foundation again of our current overdose crisis, but also harm reduction challenges, because in 2018, 2019, when Safe House, a public health group in the city of Philadelphia, in the midst of the overdose crisis, wanted to open an overdose prevention center. Hi. When they wanted to open their overdose prevention center, the Trump administration used the crack house statute to come after a health facility that wanted to create a safe medicalized space for people to use drugs and have medical intervention if they needed help. They said it was a crack house. And through a lot of legal challenges, that has still stood up. And while the Biden administration has not jumped in either way, it's technically still the law on the books that opening an overdose prevention center or a drug consumption room or a supervised injection facility could technically be viewed as a crack house, right? And while we in New York City opened 2 of these sites with the understanding with the governor at the time, with the mayor, and also with the New York Police Department, and whereas we also see the states of Vermont and Rhode Island making moves to move forward with opening their own sites, technically these sites are still in violation of federal law. And all of this can be traced back to the war on drugs. And so in talking, I think it's really important for us to talk about how our policies for over 100 years when it comes to drugs have prioritized punishment over public health, right? Using the stick of punishment and the threat of punishment and the restriction of availability of supply, tools, and spaces where people can safely use drugs, rather than really truly investing in public health and medical and healthcare infrastructure to help keep communities safe, right? And so what I argue is that the criminalization of drugs and drug-related tools created the harm reduction gap, because we created no legal framework in which people could recreationally or socially use any drugs outside of a medical setting. But that also, if you developed a problem, the only option we were going to give you is abstinence. And I fundamentally believe that closing the harm reduction gap is incompatible with laws that criminalize people who use drugs and drug use and drug-related tools and drug-related spaces. And I believe that we need to shift away in our paradigm from an all or nothing or black and white thinking when it comes to drug and drug-related risk. Abstinence isn't the only way to reduce drug-related risks. It's a way, but not the only way, right? So what do I argue we need to do to close the harm reduction gap? I think we need to do 6 things. First and foremost, we need to provide age-appropriate, developmentally appropriate, fact-based drug education and resources. And again, this should be age-appropriate. So when it comes to young people and children, right, the same things that we teach young people about, like, don't, you know, because one of the biggest calls to poison control for young people is that they eat cleaning products, household cleaning products. They drink the detergent, or they eat the Tide Pod, or they're drinking the purple Fabuloso from under your counter because it's purple. It looks like a Kool-Aid drink, right? So we need to be teaching young people not, you know, about don't try to drink anything out of anybody's bottle, like out of any bottle. Don't take anything out of certain things. Like, be mindful of what you eat. Only eat what's been given to you. Only eat what comes out of the refrigerator, right? We need to give developmentally appropriate education, but also when it comes to drugs, we need to acknowledge that while just say no is an important message, we also need to educate young people as they get older, especially the older teens, about what to do in case they or their friends use substances. Overdose is the 3rd leading cause of preventable death among young people today. That is after car accidents and gun violence. Drug overdose deaths are claiming the lives of our young people. And many of these young people do not know how to identify the signs of an opioid overdose, and they don't know what to do, right? And it's really important for us even to acknowledge that young people, even if our young people aren't using drugs, and research actually shows that young people today are using drugs at lower rates than they were when I was in high school in the 90s. But that the drugs that they're using are more lethal. And so the few kids who are experimenting don't have the tools and the skills to stay safe. We need to have naloxone available. We need to teach young people how to recognize the signs of alcohol poisoning and opioid overdose. We need to teach them that you can't let someone sleep it off. You need to teach them that like putting someone drunk in a shower isn't going to sober them up. We need to teach them all of these things, right? Because even if they themselves aren't the ones using the substances, they should know how to keep each other safe. But developmentally appropriate drug education doesn't stop at youth. We should also be educating our older adults. Boomers today are smoking marijuana at some of the highest rates compared to other older age cohorts that have passed through American history. And older adults today need education around how cannabis may interact with their heart medicine. How drinking at an older age may affect your liver differently with the other kinds of medications that you're on, and that your tolerance changes as you get older. Remember, harm reduction education shouldn't be focused on any one drug class, and it should be focused on helping everyone learn about how to stay safe with drugs, right? In addition, we need more comprehensive harm reduction programs. Currently, syringe service programs, SSPs, are the predominant kind of model that most of us know about for harm reduction. However, not everyone is going to inject drugs. As I said, many people who use stimulants smoke drugs. And oftentimes, because of state paraphernalia laws, harm reduction programs can't give out smoking equipment. And we need to advocate to allow for state carve-outs so that smoking equipment can be distributed and so that we can engage people who smoke drugs in harm reduction programs as well, because they still need HIV testing, hepatitis C testing. They also need access to naloxone. But if they associate harm reduction programs only for injection drug use, they may not walk in the door and they may not get the tools that they need. And as I showed you in the first slide, methamphetamine is the #2 drug involved in overdose deaths nationally, and cocaine is the #3 drug involved in overdose deaths. People who use stimulants need to be brought in for services, and oftentimes giving them the safer tools to use their drugs can then be a touch point to bring them in to get other kinds of services. Look what else we can offer you. Look what else we can teach you. Look what else we can support you with. And it can also be a tool for racial equity. One thing that I haven't mentioned yet is that Native people have the highest rates of methamphetamine-involved overdoses nationally, and Black people have the highest rates of cocaine-involved overdose deaths nationally. And so again, offering smoking equipment, particularly for people who use stimulant drugs, is also a racial equity issue, because what our overdose numbers are telling us is that Native people are not getting enough access to harm reduction, particularly Native people who use stimulants. And in the same way, Black people who use stimulants such as cocaine are not getting access to harm reduction. And so we need comprehensive harm reduction programs where people can get, regardless of the drug that they use, the tools to use them safely, and then use that touch point to engage them in other kinds of support. We also need overdose prevention centers, places where people can use their drugs on site and be monitored for an overdose, because overdose prevention centers acknowledge that not everyone's going to call 911 when an overdose happens in their community, and not everyone uses drugs with someone else watching by to keep an eye on them to see if anything goes wrong. And so overdose prevention centers are a key part of the harm reduction strategies we need, because some people are going to need these spaces where someone can be there to keep an eye on them. And research for decades internationally has shown that overdose prevention centers do not encourage drug use in surrounding neighborhoods. They don't increase crime in surrounding neighborhoods. Instead, they simply serve as a place where people can go to stay safe, but then also get connected to other services. The 2 overdose prevention centers here in New York City offer HIV and hepatitis C counseling and treatments. They also help connect people to buprenorphine and other forms of treatment. They make housing referrals. They do laundry and showers on site. They offer acupuncture and counseling sessions. They offer hobby groups as well. They have a garden in the back. So these are places where people can come and be part of a community and also get all their other needs met. Fourth of all, we need to integrate harm reduction principles into the kinds of therapy and counseling we provide. When I worked at the syringe service program, I received counseling training in harm reduction psychotherapy. So I was able to still use all of my clinical skills, but towards outcomes that were not solely abstinence oriented. So we talked about frequency of use, mixing drugs, reducing their quantities. We talked about moderation. We talked about different kinds of drug-related goals, monitoring their mindset and how that affected their drug-related choices, talking about what are your goals, what would you like to do? And harm reduction psychotherapy should be integrated into more treatment facilities because unfortunately, if 90% of people who have addictions aren't walking into treatment facilities that are largely abstinence only, a huge subset of them might walk into treatment if they knew that they could talk about moderation goals or cutting down or saying, yeah, I think that alcohol is my problem, but I can smoke weed sometimes. And if you're not going to let me, if you're going to kick me out because I'm testing positive for weed, even though alcohol is what's been leading to all the problems in my life, then I'm not going to get any help from you at all because you won't help me on my own goals, right? On my own terms. The other thing that we need is harm reduction mutual aid groups. Right now, most of our communities have Alcoholics Anonymous or Narcotics Anonymous groups, which are incredible sources of support. They're free, they're available all times of the day. You can go in your community, you can find a group anytime, and they're super helpful for people. But the problem is that sometimes those groups aren't the most supportive if you're on methadone or buprenorphine. And oftentimes these groups aren't very supportive. Again, if you say that, yeah, I'm not drinking anymore, but yes, I'm doing a little bit of marijuana on the side, or, cocaine was my big problem, but I feel like I can have a couple drinks if I'm socializing. And again, we need more harm reduction mutual aid groups where people who use drugs but are trying to engage in healthy supports can at least support each other towards their other kinds of goals because not everyone can afford treatment and not everyone's going to go to treatment. And then lastly, I would argue that we need some form of a safe supply of drugs. With how unpredictable our drugs have become with fentanyl, but also other additives and adulterants like xylazine, etizolam, nitazene drugs, people who even want to stay safe while using drugs can't always reduce every risk because every bag of drugs that they buy is of a different composition. And so we really do need to talk about ramping up the availability of drug checking, advanced drug checking with machines that can help tell you there's this much cocaine in it, there's this much, other cutting agent, this is what else we find in it. There might be some other drugs in there so that you can make better choices for what you're consuming and that you can take more precautions, right? And so where does public health and medicine and where do all these other fields fit in? I think that it's really important for us, if we want to close the harm reduction gap, first and foremost, to stop distinguishing between like the legal drugs and the illegal drugs and the good drugs and the bad drugs and the medicines versus the recreational drugs, and to really serve all people who use mood-altering substances as communities who could be educated and receiving support and staying safe, right? And that's why I talk about alcohol so much during this presentation, because it's not just about illegal drugs. When it comes to harm reduction, we need to educate people who use all drugs, right? The other thing is that we need to think about the micro, meso, and macro ways in which we can close the harm reduction gap. And some of the ways that we need to do this and in our individual day-to-day practices is through researching and implementing more evidence-based practices in our work, which includes access to methadone and buprenorphine, two medications which aren't readily available in our traditionally abstinence-only world, but also to understand how our participants are experiencing our programs and to develop our programs to meet their needs. And oftentimes our participants do not want an abstinence-only type program. How do we respond to client preferences and patient preferences and incorporate what they want into what we are offering them? Because they are dying when they're not connected with services because what services offer are not what they want, right? And at the meso level, we need to kind of evaluate what's happening in our programs. Are we losing clients because of their drug testing results, because we are so rigid in what our expectations are? Are we excluding inadvertently or on purpose certain populations of people who use drugs who actually are dying at higher rates of overdose in our community? Thinking about racial equity, thinking about stimulant users, thinking about who's coming and who's not coming and who's dying in our communities because they can't get what they need. And thinking about our policies to make them so that they're helping people stay retained in services rather than kicking them out. Is our drug testing policy actually the reason why so many people are getting kicked out because they're seen as non-compliant with our rigid abstinence-only requirements? Is our insistence on getting people to go to 12-step abstinence-only Alcoholics Anonymous meetings, in conflict with people's religious and spiritual and moral values, so that us requiring them to surrender to a higher power is actually something that's leading them to not want to engage in our services, right? And lastly, thinking about the kinds of policy advocacy you can get involved in through your own professional associations to come out in support of evidence-based interventions, but also harm reduction informed interventions to ensure that we are closing the harm reduction gap. And on that note, I will stop my screen share, and I'm happy to take questions. Harm reduction mutual aid groups is, so there's quite a few harm reduction mutual aid groups that exist right now. There is a group called Moderation Management, which is a really great tool. Like, it's a great support group for people who drink alcohol. There's HAMS, Harm Reduction for Alcohol. There's also Life Ring, which is a non-spiritual approach to recovery. And then there's one group called Harm Reduction Works, which is a mutual aid group that uses a script and some kind of a little bit more structure. And a lot of their groups are available on Zoom for folks to join. And so there's a lot of research on these kinds of mutual aid groups and their development in engaging people towards the goals that they choose. And it's often for people who've self-selected out of AA or NA or some of these more 12-step or abstinence-only groups because of the spiritual stuff or because of the abstinence-only kind of requirement. But we need more research. We absolutely do need more research. Any other questions? Any other thoughts? How do we get people in a rural community to get involved with programs like this? The harm reduction support groups or harm reduction like syringe service programs or because both. Okay. So in rural communities, a lot of harm reduction programs do really good outreach work because they understand that in rural communities, sometimes public transportation is non-existent or it's really hard to get around. So, there's really great harm reduction orgs in rural communities who often do more like mobile outreach or street outreach because they know that they should go to kind of where people congregate or where communities are, oftentimes in their vans or through visiting different kinds of encampments and things like that. A lot of people in rural communities also benefit from like mail order harm reduction programs where they can order naloxone and get it delivered to their home or order syringes and other smoking equipment to their home. A really great program that does a lot of mail order work is an organization called Next Distro. And depending on your state laws, they will work in accordance with state laws, and they support programs on the ground that do that kind of mail order support. Unfortunately, there aren't any overdose prevention centers in any other part of the country other than the two that are currently operating in New York City. But in some communities, hotlines have emerged where people can call, like the Never Use Alone hotline or the Brave. There's several other kinds of calling call-based systems where if you are in a rural town, you can call the hotline and tell them like your address and where you are while you're using. And then if you don't respond within a few minutes, they can call and get an ambulance dispensed, sent to your home because you might have had an overdose. And then when it comes to mutual aid groups, I think the Zoom-based harm reduction works is a really great option for people in rural communities because all you have to do is call in on your phone for a support group or join a Zoom and you don't have to go anywhere. Do you happen to know what the main funding streams are for our overdose prevention centers? Yeah, so currently, um, the governor has not agreed to offer up any opioid settlement funds to help support the overdose prevention centers that are operating. So they are privately funded through foundations and through donations. And it's really unfortunate because in most other countries where overdose prevention centers exist, um, there are over uh, there are over 200 overdose prevention centers in operation around the world. And they've been in operation in parts of the world since the 90s. Overdose prevention centers are not new. There are dozens operating in Canada, many of which are funded by various public health entities. And in many European countries, the government funds them themselves. I was just in Scotland last week, and uh, actually last week and this week, because it's Thursday. On Monday, I went to the site where their overdose prevention center in Glasgow is opening, and it's being funded by the government. So only in the US is funding an overdose prevention center controversial. And as I told you, it's only because we have the crack house statute, because the drug war in the United States built the foundation for criminalizing these sites. Other countries don't have these kinds of laws. And in many of these countries, because they've never seen harm reduction sites as criminalized sites, the government funds them because they're public health interventions, because they're seen as medical healthcare facilities. Oh, we've got another Sheila. Hi, Sheila. With the history of criminalization of drugs and drug use, what do you think is the first or most important first step? Ooh. Uh, First step to addressing the harm reduction gap? And if it is at a national level of control, then what can we do in our local communities as a first step? So, I mean, I think that the first step in your community is to make sure that you have been able to decriminalize syringe access, smoking equipment access, and drug checking access. Check your state laws. Is it legal for people to distribute syringes and have syringe service programs operational in your state? Is it legal for them to distribute smoking equipment? And is it legal to distribute fentanyl test strips? Because you're in 6 different states, I have no idea what each of your state laws look like, but those are the first steps to closing the harm reduction gap, because we need to make the tools available for safer use so that we can engage high-risk, marginalized people who are using drugs to come out of the shadows, to come to our program. So first and foremost, working towards your paraphernalia laws to make sure that people can get the tools that they need to stay safe. Then the next step is to think about your state laws around drug possession. We know that drug-related possession arrests are one of the leading causes of arrests nationally and are probably a leading cause of arrest in each of your states. If you truly believe that drug use is a health issue, you know that arresting someone just for possessing drugs is not the way to get them to health or wellness, and that building up their criminal record so that it's a mile long just over possession will actually keep them from ever building a life in recovery, because it keeps them from being able to go back to school and get financial aid sometimes. It may affect their ability to get a good paying job. It may affect their ability to get good housing or pass a background check or reunite their families. It may lead to deportation. So advocating for the decriminalization of drugs is also another way to close the harm reduction gap in your community. And then, of course, looking at efforts in your communities to potentially open overdose prevention centers, places where people can use drugs on site. Okay, Grace. Yes, you'll get access to the slides. Okay. Any other questions? You still have me for a few more minutes.
Sheila, this is Sheila again.
Hi.
I'm trying to formulate this question. I'm not really sure how to say it. How do you balance the decriminalization and offering spaces for safe legal use of substances with the challenges that come about with like commercialization of substances? And so like the trends that we're seeing around marijuana across the country, that those same types of challenges could come up regarding other drugs as well. So that's real. I'm really struggling with the balance there.
Yeah. So decriminalization and legalization and regulation are all different words. So decriminalization makes something no longer a criminal offense. There are 2 kinds of offense categories: civil offenses and criminal offenses. Criminal offenses involve getting arrested, getting charged, getting booked, potentially going to jail, and getting a criminal record, right? But civil offenses are like parking tickets, speeding tickets, loitering, right? Well, no, maybe not loitering. But civil offenses are ones where you can get tickets, but it's not going to lead to you going behind bars, right? And it means that you don't have to worry about getting arrested. So when I say decriminalizing drugs, it means that they can't get arrested by a law enforcement officer, which means that they don't get potentially charged, they don't get potentially put behind bars, and they don't get a criminal record. Legalization is when you say that possession of certain quantities is not criminal or civil, right? So legal possession of a drug still just means that you're not getting arrested. Regulation is when you actually have laws in place over how something is produced, how something is sold, and who it's sold to, right? So in states with marijuana legalization, they have legalization and regulation, right? So if you're found with marijuana in your pocket in a legalized state, regardless of where you got it from, it's legal to have. And if you want to, you can go to a regulated store to buy it. Does that make sense? So those are all different words, just to be clear.
Okay. So what I'm hearing from you is that there are ways to make drug use safer without making drug use everywhere readily available to everyone who wants to walk into a store and buy whatever they want and use it any way they want.
Right. So there's a continuum, right? So if we're looking for first steps in your community, the first step would be to not have drug possession be a criminal act, right? To make it a civil act, right? Or a civil offense, so that people who are found in possession of drugs do not worry about getting arrested and getting sent to jail for that, right? They might get a ticket, they might get a fine, or they might be diverted to talking to a social worker or, you know, getting connected to other services, right? So decriminalization is one step. I would argue that legalization, also just saying that if someone has drugs in their pocket under a certain quantity, they won't get arrested or they won't get a fine, I think is also totally fine. Regulation can look like a lot of things too, though. So we can have models. I mean, the commercial model of regulation where a store on every corner, open to anyone, advertisements on, you know, commercials on television or billboards. That is one form of commercialized regulation, but there are other forms of regulation as well, right? There are pharmacies. You know, in some countries, there is heroin-assisted treatment where actually it's a medicalized option and availability of heroin. So that's a form of regulation because just like we offer methadone and buprenorphine in places like Switzerland, they have offered heroin as a treatment for people who are addicted to heroin. They come to the clinic, they get to inject on site at the clinic, and then they go home. And so it's technically legal and it's technically regulated. It's a known quality, but it's only given to patients who are enrolled in the program. And so there's other forms of regulation, including also like buyers clubs and compassion clubs, places where people procure the drugs and they only sell it to known members at cost. There's no advertising, there's no commercialization, and you can get your doctor to prescribe it to you. So there are other ways of legally regulating drugs that doesn't just look like a storefront on the corner. Allowing anyone to walk in, you know, it can look like people having to give ID. It can look like people having to complete an education course before being able to buy a drug in the store. It can look like a lot of different things, right? I think
That is super helpful. Thank you.
Yeah. I got 2 more minutes. Anyone else? Okay. Jen, is there anything you want to say as we wrap up?
We do have a few more closing things that we will go through, Sheila, oops, looks like there's one more question.
For those of us working organizations that restrict policy, yeah, I mean, I think, the organization where I work, the Drug Policy Alliance, has a lot of really great resources. I can drop the link. We've got a lot of fact sheets, resource pages, things that could be super helpful. So I'm going to drop it in the link here, drugpolicy.org. I had mentioned Next Distro as another place that does mail order harm reduction supplies, but they also have really great fact pages, like fact sheets and resources and manuals and tips that would be really great for your participants. Yeah, so those are some sources where you could get more information.
Excellent. And I would echo many of the wonderful sentiments in the chat. It was a wonderful presentation, Sheila. Thank you so much for joining us today. For those of you who have stayed on, if you want to just hang on for one more minute, we'll go through the closing. There have been some questions about what happens next. So just to tie off, for those of you who are looking for certificates, real quick, we do want to make sure that you get the post-event survey. That helps us let Sheila know and the Technical Center, our team, know how this event was for you, what more information you're looking for as we go into our third year of planning for virtual education. We thank you for being with us throughout the last couple of years, and we look forward to planning for the next year ahead. So please make sure that you give us some comments and suggestions about how this event was for you. The first 5 questions are especially important with regards to that. In terms of the availability of this content, give us a couple of days to get that closed captioned and put up on the website for you. We always follow up with getting that session content out to you. We send it out to everyone who registered, and then for those who participated, we make sure that we get your certificate of attendance. If you haven't heard anything from us in about 2 weeks, please feel free to reach out to me directly or through the Technical Center's email. With that information at hand, here are our contact links. We'll make sure to put all of that in the chat so that you can get access to it, or if you want to just do a quick screenshot, either is okay. So it's our email or website, our newsletter. You can get archived newsletters. You can get the up and coming newsletter. We just launched this month's newsletter this week. We are on Facebook, so you can follow us there to make sure that you know what's up and coming for virtual education, and follow some of our partners. And again, if you're looking for technical assistance in your state, as far as our region, we will absolutely help you get connected to that, to one of our ROTA state offices. If you're looking outside of our region, we always offer a no wrong door policy. We can help you get connected to the ROTA-R center in your region as well. And I'm going to stop the share there. As far as what is coming up for October, we do have, we just solidified education for October, and it will be mental health stigma in rural communities. That is up on our website, but we did not have it in time for Sheila's presentation. That will be October 8th, which is a Tuesday. It will be from noon to 1 with Jeff Winton. So please check our products for that information. Again, thank you, Sheila. It was a joy to have you. We're going to stop the recording there.